Hi, welcome back to MedEd Seminar's CMC CSC exam review, and I'm still Cammy Christie, still with you for this whole entire program. So we have really talked about, cardiac anatomy, physiology, assessment, hemodynamics. We talked a great deal about coronary artery disease and heart failure, and a little bit of atrial fib. Now we're going to talk about valvular disease, which is a big component of what we do. And if you see any questions on the exam about valvular disease, I want you to always think heart failure, because it doesn't matter if you have aortic stenosis or aortic regurg, mitral stenosis or mitral regurg, that patient is going to have heart failure. So we just did, the last one was heart failure, and that's a pretty lengthy module with a lot of information. So if you need to, it's not bad to review heart failure before we go on to valvular disease. In the adult, valvular disease is either congenital, that means the patient was born with this valvular discomfort or this problem, and it was usually an abnormal embryonic development at some time, right? We usually find it out very early in life, and hopefully we can fix it. Acquired, most likely in the adult, is secondary to inflammatory or rheumatic disease, which in the United States we don't see as often as we did in the 50s, 60s, and 70s. So what we see today is just the degenerative disease of aging and of valvular dysfunction. So these are the things we see today. In the adult, we mostly see problems with mitral and aortic disease, and probably the most common is aortic stenosis. Your heart can really take a volume overload for a while and continue to contract and continue to have good function. But a pressure load is very difficult for the heart. That means it has to work much harder to pump that blood out through that narrowed valve or that SVR that's 2300. So volume overload is easier for your heart to overcome than pressure overload. And when we talk about valvular disease, that's what we have to talk about, is the pressure required for that atrium or ventricle to get blood out that narrowed opening. Medical management, there's really not a lot we can do once the patient has now gotten valvular disease. What we can do is certainly prevent infection. About 20 years ago, the American Heart said, if you have mitral valve prolapse, you no longer need antibiotic therapy before you have an invasive procedure. And a couple years later, they said, oops, that's not true. If the valve is irregular, if it's redundant, or it has a hole in it, or it's calcified or thickened, if the patient has bacteremia or viremia or fungemia, that's where that fungus, virus, or bacteria is going to go, to that irregularity. I don't know if you've ever noticed, but people who have fistulas, dialysis fistulas, if they get a bacteremia, where does it go? It goes to that fistula, and oftentimes they need IV antibiotics. Sometimes that fistula has to be removed. So if you have an irregular valve, you're going to get that bacteremia at that valve and cause endocarditis. There are not too many questions about endocarditis, but remember, in endocarditis, if the valve is really malfunctioning, that valve has to be replaced, and the patient is on IV antibiotics, usually depending on what is it bacteria, viral, or fungus. Fungemia, fungal valve infection, is very bad prognosis, because look at the antifungals that we have and the complications that we have with those. So they need IV antibiotics for 6 weeks, sometimes for lifetime suppression. Prophylactic drug therapy, treatment of heart failure, that's the key. These people all will have heart failure. Treatment of dysrhythmias, atrial fib, PACs, atrial fib. And then surgical intervention when the time comes and they meet the criteria for surgical intervention. So the first thing I'd like to talk about, now this is quite extensive, and if you need to get up and move around, please do. Mitral stenosis is when the mitral valve gets thickened and stiff, and the commissures, the different valves, may fuse together, and now you have a very stiff valve. So the atrium, imagine, the atrium has to work much harder to get blood from that left atrium to the left ventricle. So it's usually from rheumatic disease, bacterial infections, maybe even tumors. Remember, tumors of the heart are very rare. Cancer of the heart is rare. It produces that very narrow opening, very turbulent blood flow, and left atrial enlargement, high pressures. And that left atrial pressure is transmitted to the pulmonary veins. So you can imagine what this patient feels like. Approximately 40% of the patients have rheumatic disease have a combined mitral stenosis, mitral regurg, right? So the valves are thickened and stiff, so the opening is narrowed, but it doesn't close all the way. So they have a little bit of regurgitation too. Majority of patients with mitral valve disease are women, and usually in the 3rd to 4th decade of life, they need treatment. They need treatment. Long term, what does this cause? If you don't get your mitral valve fixed, the commissures may fuse and make it even more stiff and more difficult to get blood flow, fibrosis and thickening, calcification of the leaves. This is a terrible progressive problem, right? The normal valve area of the mitral valve is small, 4 to 6 centimeters. The aortic valve is much bigger. There should be no gradient. There should be no step up of pressure from the atrium to the ventricle. Remember, the LA pressure is about 5 to 6. The LVEDP pressure, left ventricular end diastolic pressure, is 5 to 6. When you have that mitral stenosis, the aortic pressures might be 25 and the ventricular pressures might be 5. So you have a gradient across there. Critical mitral stenosis occurs when the mitral valve opening is less than 1 centimeter. That's like a fingertip, right? So mitral stenosis is going to cause shortness of breath, dyspnea, fatigue, palpitations, atrial fib, hemoptysis, because the pulmonic veins are so distended that this patient is going to cough up blood. Thromboembolism, they're going to have, problems with that. Hoarseness, signs of right ventricular failure. Now remember, here's the left ventricle, it's normal. The valve, the mitral valve, is stenotic, so the left atrium is very enlarged, high pressure. That's mitigated to the pulmonary pressures. If the pulmonary pressure is getting higher and higher, the right ventricle has to work very hard to get blood all the way across, so they have right-sided heart failure. Signs and symptoms of right-sided heart failure. Mitral facies is their little capillaries in their cheeks kind of rupture, and they have very red cheeks. Palpitations, these are patients who go into atrial fib. The left atrium is distended. Anytime you stretch the atrium, you have PACs and atrial fib. Auscultation, you'll hear a very loud S1 and an opening snap, right? That mitral valve, remember, is going to open, and when it does, it's making a noise. It's going to snap, and a low-pitched diastolic murmur, mighty. Is chest x-ray, EKG. The real diagnosis is an echo. Let's get an echo. Echoes are fabulous at showing structural abnormalities, especially of the valves. Natural history, the patient may go 5 to 10 years with onset of symptoms, but usually they get totally disabled in later life. Without surgery, the mortality is about 50% at 10 years. If they have class 3, 85% at 10 years. So a nurse came up to me and said, my mom is only 8 years old, and she's been diagnosed with mitral stenosis. She's been short of breath, she's had some fatigue, and she doesn't feel well. And the doctor did some evaluation and said she had mitral stenosis and needs her mitral valve repaired or replaced. And because she's only 55, if she gets a replacement, it will be a mechanical valve, and she's deathly afraid of Coumadin. She doesn't want to take it. So the nurse is asking me, how long can my mom wait before she has to have surgery? And I said, well, you want her to have surgery right before she goes into atrial fib. And the nurse gave me a dirty look and said, well, how do I know that? And I said, well, your cardiologist should be doing echoes, serial echoes, every 3 or 4 months. And when they begin to see reversal of flow in the pulmonary veins, that's when the pulmonary hypertension is occurring and she's going to go into atrial fib. Because if you wait until she goes into atrial fib, what can happen is she will not have reversible pulmonary hypertension. She'll have fixed pulmonary hypertension. So the surgeons will be very happy to put in a new mitral valve. She'll go through all the ordeals of having surgery, and that is open heart surgery, and she'll still be short of breath. The mitral valve will be working perfect, but she now has pulmonary hypertension. So we want to get this fixed before the patient has pulmonary hypertension. Often these patients had atrial fib, so if we're going to put a new valve or do a valve repair, we can do a mini maze, a combination procedure where we interrupt the pathways of that atrial fib, atrial appendage, excision, or clamping, so that that atrial appendage is not going to make clot anymore, right? So we want to fix that atrial fib. Now this is a very detailed, and I'm sorry, and I can't even see it myself very well, but here's mitral stenosis at the top, and there now is a pressure gradient between the left atrium and the ventricle. The left atrial diastolic pressures are higher than the ventricle. So what you'll see is high atrial pressures, and then look at the left. Left atrial enlargement, it gets enlarged, so thrombus formation, so they're going to have thrombus in the left atrium, left ventricle, stroke. Mighty. Predisposition to atrial fib because of the stretching, thromboemboli, they're going to have a stroke. Look in the middle, pulmonary venous pressure goes up. Remember the left atrium, 4 venous pulmonary veins, the pulmonary veins to the alveoli, and then the pulmonary arteries. So you're going to have pulmonary hypertension, right heart failure over time, hepatomegaly, remember all the things we talked about with right ventricular failure, increased JVD, and peripheral edema. And then look over, way over on the right now, elevated or eventual left atrial failure with decreased atrial stroke volume, decreased preload, decreased cardiac output, and severe fatigue. So they're going to have heart failure signs and symptoms. They're fatigued and short of breath. Mighty. So we want to get that placed before. So the indications are class 3 and 4 heart failure. Look at the size of that aortic valve area. If it's less than 1 centimeter, for sure they have to have surgery. And history if they've had clots, if they've had a stroke or whatever. Now we have to wait after they have that stroke, but because they're going to have to go on bypass to have that mitral valve repaired or replaced. Post-op mitral valve replacement. Their left ventricle is a very small cavity because it hasn't been getting much blood. So it's small, so they're very prone to low cardiac output syndrome. Alrighty? So it looks like diastolic failure. So you have to maintain, and there's like 4 asterisks here, you have to maintain filling pressures. If this patient gets dehydrated or we over-diurese them, they'll have no cardiac output. Alrighty? They had heart failure before, they're going to have heart failure after, but it's diastolic dysfunction. You have to fill that ventricle. Alrighty, they might need lusotropic drugs. And they might often go into renal failure because of low cardiac output. So mitral stenosis, just think about it in your head. That mitral valve is tight, tight, tight. Here's a ventricle, it's waiting for blood from the atrium, but the atrium has to increase the pressure to get through that smaller and smaller orifice. The afterload is immense. The oxygen required is immense. So it doesn't work well over time. We want to maintain sinus rhythm if we can, right? Maintain a MAP, usually of 70-75, a good MAP, so have good coronary blood flow. And maybe they're going to have now resistant pulmonary hypertension, so they might need pulmonary vasodilators, Flolan, nitric oxide, those kinds of things, and maintain perfusion. Alrighty. Now mitral regurg, now that valve is incompetent. So every time the left ventricle contracts, some blood goes out the aorta, but a lot of blood goes to the atrium. So the atrium again is going to get distended. Most common cause is that ventricle is dilated and pulled the mitral valve apart. Right? Maybe myxomatous disease, it might be prolapse, it might be endocarditis, it might be rheumatic heart. Those are all the kinds of things. But remember that mitral valve is held in place by the chordae tendineae and the papillary muscles. So again, mitral regurg, is it acute or is it a more chronic type of thing? Acute mitral regurg is a 911 call. They have acute myocardial ischemia, they could infarct, they rupture their chordae tendineae, and now that valve leaflet is just flapping around. So every time that left ventricle contracts, blood is shooting up into the left atrium, left atrial hypertension, pulmonary edema. This patient goes into florid pulmonary edema, and you can't fix it with Lasix or preload reducers. Patient needs surgery. Chronic mitral regurgitation is going to be progressive in nature. You're going to have compliance problems in the left ventricle and the atrium, followed by very dilatation of the ventricle. It's a bad thing to happen. The carotid pulse, now when the patient has aortic regurg, the carotid pulse has a very rapid upstroke. So when you're feeling that pulse, bam, it goes up. It's very hyperkinetic because the heart is pumping as hard as it can. They have JVD, they have an S2, it's widely split, so split S2, and a pansystolic murmur. Mitral regurg, pansystolic. Remember, in Sicily, what's that mitral valve supposed to do? It's supposed to close. Now it's open, so you have blood going in the opposite direction, turbulent blood flow. So harsh blowing murmur, right? So chronic fatigue, dyspnea on exertion, palpitations, atrial fib, emboli, systemic emboli, hemoptysis. Acute, abrupt onset of pulmonary edema, papillary muscle dysfunction, and you're going to hear that murmur. It's very important to remember that murmur. You didn't hear it before, and now you hear it, and the patient goes into pulmonary edema. That's a 911 call to their providers. All right, mitral regurg, acute. Let's look at acute first. This is bad. This is mitral valve, the chordae tendineae rupture, or the papillary muscles. So left atrial volume goes way up, left atrial pressure goes up, pulmonary vein pressure goes up, pulmonary congestion, dyspnea, pulmonary edema like that, pulmonary edema. And what do you have to do? You have to go to the OR and fix that. Chronic, now you can look at both sides. So right in the middle, left atrial volume goes up, left atrial enlargement, dysrhythmias, pulmonary emboli, okay, strokes. Increased atrial pressure, pulmonary hypertension, dyspnea. Bidirectional left ventricular ejection. So what that means is here's the left ventricle. It contracts. All that blood should go out the aorta. But the aorta pressure is higher than the atrial pressure. So when it contracts, blood goes that way and that way. And probably more blood is going to the atrium because it's lower pressure. So you have very low ejection fraction, very low. And you really can't tell because when the echo comes, they look at the left ventricle at the end of diastole and at systole, and they subtract those two volume, give you ejection fraction. But when that left ventricle is contracting, not all the blood's going out the aorta, it's going to the atrium. So low cardiac output, fatigue, low blood pressure, kidneys stop working, right? For acute mitral valve regurgitation, they need to go to the OR and cardiogenic shock. These are people we might put balloon pumps in and Pellas in, although the problem is not in the ventricle, the problem is in, well, you can suck the blood out of the ventricle and put it in the aorta, mighty. They might have acute endocarditis with hemodynamic problems. They could have sepsis, they could have septic emboli, all the problems with sepsis with the endocarditis. If they have class 3 or 4, and an early operation to prevent atrial fibrillation. Now, in endocarditis, let's just talk about that a second. Endocarditis of the mitral or aortic valve. Remember, those two valves just have one tissue plane between them, and that tissue plane is a septum with a bundle of His. So if they develop an abscess on that internal part of the valve, then the abscess begins to eat through the conduction system. So if you have a patient with endocarditis and they develop heart block, all of a sudden they've been in sinus rhythm, sinus tach, and now they're having type 1 heart block, type 2 heart block, your provider needs to know because that abscess might be extending and they need intervention. Alrighty. Post-op mitral regurg, again, this ventricle is just not working right. So they often need inotropic support because they have low cardiac output syndrome. We have to take care of that. The ventricle has to reshape. Remember, the chordae tendineae are not working, so the ventricle dilates. For it to get back to normal shape, it takes up to 3 to 4 months after the valve is fixed. So reduction of pulmonary hypertension, reduced filling pressures. Now here's a key with the PA catheter. Remember that I said the pulmonary artery diastolic pressure is usually very close to the wedge. The wedge is always 1 or 2 lower than the PAD. Here, the PAD might be really high and the wedge might be really low because you have mitral regurgitation. Blood is going in the opposite direction. So your hemodynamics are going to be very different. That's why sometimes in this patient, if they're very, very sick, surgeons used to put in left atrial lines so we could actually measure the atrial pressure, right? LA lines. Sometimes we can put, with a PA catheter, you can put direct pulmonary vasodilatation with nitric oxide prostacyclins right into the pulmonary circulation. That works very well in these really, really sick mitral patients. You got to keep this patient in sinus rhythm. So a lot of times they come out of the OR and we're pacing them at a very faster rate than their baseline rate. Maybe their heart rate is 75. They're in sinus rhythm. Cammy, why are you pacing? Because I don't want this patient to have a PAC and I don't want them to go into atrial fib, so I'm overdrive pacing them. I'm pacing their atrium at a higher rate, maybe at 90, maybe even at 100. Left ventricular rupture, tamponade, that's a big problem with these patients, righty? Aortic stenosis, most common thing you see, can be congenital, and the congenital is usually a young man that has a bivalve instead of a triple valve, and so he has, or just a univalve. So majority of cases it's thickening and the valve leaflets don't work, but it could be congenital. Normal aortic valve area is 2 to 3.5 centimeters. Remember, the mitral is much smaller, much smaller. So now with aortic stenosis, what's happening? So here's your left ventricle, here's your aorta, your pumping blood goes out, no problem. But over time, that aortic valve is getting smaller and smaller. Now the ventricle has to squeeze higher and higher, harder and harder, increased afterload, increased workload of that left ventricle. And if you have a muscle that you're increasing the workload over time, it's going to get thick and stiff. The ventricle gets thicker and stiffer. You have diastolic dysfunction. Alrighty? It's more common in men. They have a unicuspid or a bicuspid valve or unequal valves. That's a congenital problem. Usually happens earlier. So we see men in their 20s and 30s coming in for aortic valve replacement. I'm trying to think of what's his name, the famous actor who had a congenital bicuspid valve and later on had aortic valve surgery but didn't want to be on Coumadin. So we did a Ross procedure where you take the pulmonic valve and put it in the aortic position and put a tissue valve in the pulmonic because it's low pressure. That used to be a very old procedure that we did many times, but it's not very successful. It doesn't last very long, and he had to have a replacement done just a few years later and have a real aortic valve put in. So remember, this is obstruction to the outlet. The left ventricle, where is it coming out of? The aorta. Very high pressure, very high LVEDP, very high gradients between the aorta and the valve. And the left ventricle. Remember, the diastolic pressure in the left ventricle is 6. The systolic pressure is 120. So the systolic pressure in the aorta is 120, 120. Well, with aortic stenosis, the systolic pressure in the ventricle might be 200, where the systolic pressure in the aorta is 100. So there's a big pressure gradient between the systolic pressure of the ventricle and the systolic pressure of the aorta. And that overloads the left ventricle. So they get left ventricular hypertrophy, diastolic dysfunction, decreased cardiac output. Tissue compromising, your kidneys are going to go, liver, lungs, brain. Most of these patients have heart failure symptoms. They have atrial dysrhythmias, atrial fib. Atrial fib is one of the 3 things we worry about in aortic stenosis. We want to fix it before they go into atrial fib. Systemic emboli, myocardial ischemia. That ventricle is so thick. Remember, there's just little tiny vessels in there, and the vessel, it gets so thick that the patient has myocardial ischemia and then has dysrhythmias. Mortality rate without surgery is 25% at 1 year, but 50% at 2 years. So I know when I'm talking to a patient who has aortic stenosis, even if they're 80 years old and they're symptomatic, they have heart failure, they're in atrial fib already, I tell them that if you allow the doctors to do your aortic valve replacement, you will live longer and better. I know you will, just from the statistics of having aortic stenosis. You'll live longer and better, even at age 80. Mighty, they're going to live a longer life and feel better, and will get rid of some of their heart failure. Mighty. So it's a good thing to do. Now here's aortic stenosis, and the 3 things I tell you that we always look for in patients with aortic stenosis is syncope, ventricular dysrhythmias, failure, heart failure, and angina, and they have normal coronaries. It's because that ventricle is so thick. So look at the top, aortic stenosis, and there's that gradient between this ventricle and here. The ventricle has a higher systolic blood pressure than your aorta, righty? So left ventricular hypertrophy, outlet problems, like I said, pulmonary pressures go up, because if the left ventricle is getting higher, that's transmitted to the left atrium, the pulmonary veins, and then you have pulmonary pressures high and you have heart failure, righty? And then on the other side, the persistence of condition can lead to atrial fib, poor cerebral perfusion, and look at the bottom, decreased coronary perfusion, increased myocardial oxygen demand. Now here we have supply and demand unequal, impaired coronary blood flow, and angina. So those are things: syncope, the presence of atrial fib and dysrhythmias, failure, heart failure, signs and symptoms, and angina. That patient needs their aortic valve replaced. So again, it's not indicated for the asymptomatic patient. If you're asymptomatic, you just keep on ticking. But if your aortic valve is less than 0.75 centimeters, now I've had patients that have come in and we're doing aortic valve replacements and their aortic valve area is 0.1. It's like I don't know how they're getting a whiff of blood to go through there. Presence of angina, heart failure, and syncope are the big three, and maybe even sudden death because they go into VTAC and VF, right? Bad situation. So pre-op aortic stenosis, we have to look at the ascending aorta, because this ventricle is just pounding with the high pressure. The velocity of blood going through this little hole is very high, and it hits the sides of that aorta and can cause the aortic root to get dilated. So you can't just fix the aortic valve. Then now the patient needs an aortic valve and a root replacement. Mighty. Valve repair, valve replacement. We don't do too many aortic repairs, but we do replacements. The ascending aorta and the coronary arteries. Remember, the coronary arteries are coming out right above the aortic valve. So if I've got to fix the valve and the ascending, I may have to re-implant the coronaries. So they'll take a coronary button, take the coronaries out of the aorta, and then sew them back into the replacement. It's a lot of work. Patients could have an infarct while they're doing that. They can get air down their right coronary. There's a lot of complications because it's a very big operation. Head branches, right? You're fixing the whole root of the aorta. Post-op, same for anything. Attention to sinus rhythm, if at all. Remember, this patient has diastolic dysfunction, so they need good filling pressures. We don't diurese this patient right away. They need to be filled. They need to be filled. Now, if they become, and still on this test, the FDA has approved TAVRs for people who could have surgery. So if you're 65 years old and you need an aortic valve replacement, you could say to the doctor, I just want a TAVR. I don't want an open chest procedure, right? But for your test, this procedure is only for patients who are deemed a non-surgical candidate. So anesthesia doesn't want to put them to sleep because they're high risk. They have renal failure, liver failure, they're a bleeding problem, they have horrible COPD and anesthesia. So if I put them to sleep, they're never getting off the ventilator, righty? So we can do an aortic valve implantation or replacement, a TAVR. The key here is, it's so amazing. We do, Tuesday is TAVR day where I work, and they do like 8 TAVRs. And these are people who are not surgical candidates. They sometimes come in a wheelchair. They're smoked a cigarette while they're coming in for their valve replacement. They're terrible protoplasm. 80% of them go home on post-op day number 1 or number 2. They're fine, and they feel better, they're gonna live better, and they do better. 20% are gonna have problems. Once you put that valve in valve, remember they're gonna put a catheter across that aortic valve, they're gonna dilate that aortic valve, which might let loose some calcium. And where's that calcium going to go? They could have a stroke. It could go down. They could lose their toes. And they're going to dilate it and put a new valve in valve. And most of the time it works perfect. But sometimes it causes now aortic insufficiency, because now they have a perivalvular leak that's worse than they were before. So they're still short of breath. So 20% of the people are going to have renal failure, vascular complication, a stroke, maybe need a permanent pacemaker. Okay? All right, they're difficult cases. Right? Aortic insufficiency is usually from trauma or structural problems, inflammatory, like endocarditis, right? And long-term hypertension. Produces a volume overload, aortic insufficiency. Though the ventricle contracts, put blood in the aorta, and it comes back because the valve is not closed. The valve is not competent. So now you have this overloaded, stretched out left ventricle. So again, you're looking at regurgitant volumes. You're looking at diastolic pressure between the two. Diastolic pressure should be 80 in the aorta and 6 over here. And now it's 80 or 60 over here and 50 over here, right? So again, a pressure gradient, and it is all problems during diastole. So acute could be dramatic increase in LVEDP. Left ventricular end diastolic pressure should be 6, and now it's 25, 30, righty? With only a moderate amount of volume. So it doesn't take much volume to overload that left ventricle. Chronic AI, well, you're going to have increased end diastolic pressure, but the patient, remember, they do volume better than they do pressure. So it's not a good thing to have. So let's look at acute. Acute aortic insufficiency, terrible thing to have. Blunt trauma to the chest, valve leaflet dysfunction, okay? Left ventricular end diastolic pressure goes up. It contracts, blood goes out, blood comes back. I put out 60 cc's and 30 cc's come back. So now I have 130 cc's. I squeeze, 70 cc's go back, and 40 comes back. Left atrial pressure goes up, pulmonary pressures go up. Left ventricle is dilated. That pressure is transmitted right to the left atrium to the lungs. To the lungs. Patient looks like pulmonary edema, dyspnea, orthopnea. Okay? Right-sided heart pressures go up because of pulmonary pressures. Remember, this is a circuit. Over here, the left ventricle is overdistended. The left atrium gets overdistended. Pulmonary veins, the alveoli, the pulmonary artery, the right ventricle. So when you're failing over here, it's just going to cause this to fail over here, righty? Hepatomegaly, JVD. Chronic, you're going to have increased end diastolic pressures and hypertrophy, but you're going to have dyspnea, orthopnea, and PND. You look like you have heart failure. The volume overload eventually will cause significant heart failure, and that's how we'll treat them, righty? Chronic AI, oh, well, you might give antibiotics again because of valve problems. Once LV failure occurs, you can do beta blockers, ACE inhibitors, DIG, diuretics, vasodilators. You do the same as heart failure. Please remember, and I can't say this enough, if your patient has valvular dysfunction of any kind, they're going to have some degree of heart failure. And so heart failure treatment for this patient. Surgical treatment, we have advocated for symptomatic patients with impaired left ventricular function if they have AI, righty? Surgical risk depends on the patient's condition. How old are they? Are their kidneys working? What are their lungs like? What's the risk of them having anesthesia? These are big procedures. You have to open up the aorta and get down into that aortic valve area and do some chiseling and do some repair. So what is the ideal valve replacement? Ideal. You have to have your valve replaced. It's not going to be repaired. You're going to have it replaced. Well, it would be the right size. It would be biological. It would be human tissue, would be wonderful. You would not need to have anticoagulation, and it would last a lifetime. So if you're 40 and I give you an aortic valve from a person, a tissue person, you're not going to have to be on rejection medicines. Remember, it's cryopreserved, it's frozen. But the tissue is still human tissue. You don't need anti-rejection medicine, and it will last your lifetime. Unfortunately, what do you know about tissue valves? They don't last a lifetime. They don't. So if you're elderly, if you're 75 or 80, I can put a tissue valve in you and it'll last your lifetime, hopefully. But I have to tell you a little story. I'm interviewing a man who is 75 years old and he's getting aortic valve replacement next week. So I'm doing his pre-op and I see on the pre-op that he's getting a mechanical valve at 75. And so after I do all the histories and physical, and I talked to him, I said, now, Mr. Smith, I see here that you and your surgeon have decided to get a mechanical valve. I said, that's kind of unusual because you're 75. I thought you would want a tissue valve. He says, oh no. I had a long discussion with my father about this. Now I think he's cuckoo. I've done this whole interview. I think he's fine. And now he's talking about his father. And he says, well, wait a minute, I'll bring my father in. His father comes in. His father is 100 years old and drove the 75-year-old son to the doctor's office. So why does he want a mechanical valve? Because he thinks he's going to live to be 100. And he doesn't want to have a repeat operation. Ready? So tissue valves are fabulous. They're biogenic. They're tissue, whether it's a pig, whether it's a cow, whether it's autograft, a human being that donated their valve. It doesn't last as long. It does epithelialize. It becomes your own valve, but it doesn't last very long. And if it's going to be in the aortic position, that's high flow, high velocity, it's going to wear out faster. Mitral valve doesn't wear out as fast because it's hopefully lower pressure, lower velocity coming across that valve, but it is smaller. If you have, so you still worry about clotting on that valve. Mitral valves clot faster than aortic valves because it's a smaller area, lower velocity flow. If you're going to get a mechanical valve is going to last forever. It'll last after you're dead at 100 years old. The problem is you have to be anticoagulated the entire time that you have that valve. You can't stop. So you're 90 years old now and you fall down and break a hip and bleed to death before 911 gets there because you're on Coumadin. And your surgeons, my surgeons, will only use Coumadin for mechanical valves. They won't use Xarelto, they won't use Eliquis, they won't use anything else but Coumadin. So INRs. About 10 years ago, there was a huge study done in Africa. People that lived in the bush came in with aortic stenosis. So the surgeons put in new aortic valves and they put in mechanical valves, but no Coumadin, no anticoagulation. They went out to the bush. The problem was they didn't get really good follow-up, but many people lived many years without any complications with no anticoagulation. That's pretty amazing. So the questions we have is mechanical failure for a tissue valve, thromboembolism because you got clot on that valve, right? Endocarditis, oh my gosh, you get an infection on that artificial valve, you're in big trouble. So we have a lot of patients that come to us who are IV drug abusers and got endocarditis on both valves from their severe drug abuse. And so we have surgeons that will say, okay, this is sad that you're an IV drug abuser. We're going to get you, medical treatment for your drug abuse. We're going to get you all the treatment you need for substance abuse. We have substance abuse counselors, and we're going to fix your valve. But in some of these young people, we're afraid to put mechanical valves in because they're not reliable with their Coumadin. So we put tissue valves in. Sometimes we put a mechanical, but mainly tissue. If they come in again with recurrent endocarditis, secondary to their continued drug abuse, well, guess what? We'll put another valve in there. But then the surgeons have a heart-to-heart talk and say, if you come in again, we can't do surgery a third time. So endocarditis is a horrible thing to have, right? And it's not just IV drug abusers. It is people who got an artificial valve in this hospital, got endocarditis there, or they got an artificial valve and they went to the dentist and got bacteremic and got endocarditis, right? Perivalvular leaks. That's a leak around the new valve that was just put in. So blood should be going in and out here, and now it's coming up around here. And it will, the higher the blood flow, the higher the blood pressure, the more leak they will have, and they'll have heart failure. They'll have heart failure. They have regurgitation. Anticoagulation-related hemorrhage. I work with 8 heart surgeons, and I've worked in several places in cardiac surgery, and all surgeons will tell you. Now, cardiologists may not say this, but heart surgeons will say we have more problems with bleeding than we do with clotting. But you got that new mitral valve, and it's mechanical, you have to be anticoagulated. There's also some literature that says even with a tissue valve in either place, sometimes your surgeons will anticoagulate that person for 1 month after surgery. I mean, after they've recovered, they're not bleeding, but we'll give them anticoagulation. And of course, the age-related. Of course, my patient who was 75, his father was 100 years old and he got a mechanical valve. So this is a very important, very important. What valve should you put in? This is a good discussion, if it's not an emergent, between the surgeon and the patient's family. We did have a lady, patient's wife, said, I don't want him to have a mechanical valve because I sleep with my head on his chest and I don't want to hear that clicking all the time. And I thought, boy, I'd want to hear that clicking because I know that that valve is working. But she didn't want that, and he said, okay, just put a tissue valve in because she didn't want to hear the clicking, right? So which is the best valve to have? No valve. So we have mechanical, biological, age, occupation. What if your patient is only 40 years old, but they skydive every day? They're a skydive instructor, and they're going to be jumping out of planes all the time. I wouldn't want that person to be on Coumadin because a little accident and they break their ankle, they could bleed to death by the time somebody's coming to 911. So again, what's their occupation? They're a solderer, or they use hammers, or they have an activity that could cause great harm, right? What's the patient's desire, and whether or not they want anticoagulation. Now let's just briefly, and we're almost done, let's briefly talk about a valve repair. Now valve repair, don't do it too much with aortics, but mainly for mitral valves. The improved techniques are wonderful. There's no anticoagulation, and it's much more, physiologic. They're going to go in and repair, especially that mitral valve. They're going to repair it. Remember, with a mitral valve replacement, they're going to take out that annulus, and the chordae tendineae and papillary muscle is going to be cut. So the geometry of the heart is going to get loosened a little bit, and they're going to get a dilated heart over time. So if they do a repair, they fix the annulus, they fix the leaflets, and they fix the chordae tendineae, which keeps the geometry of the heart like a cone, not like a balloon. So that's very important. It's much more physiologic. However, how durable is it? Depends on the patient. And you might be on the pump longer because now you're going to be on cardio bypass, and it might be longer. So again, the risk and benefit. Is it more risky for you to have 2 hours of anesthesia versus an hour of anesthesia? Or 1 hour of cross-clamp time versus an hour and 15 minutes? So again, surgeon and patient. If I were 40 and I needed my mitral valve fixed, I'd want to repair. Maybe even more bleeding. What about your patients with double valve surgery? They're going to have an aortic and mitral valve replacement. Remember the positioning of those things. They're right next to each other, and that plane of tissue is the septum. So increased morbidity and mortality, longer pump run, much longer pump run, much harder for the physician to sew in those two valves without hurting that conduction system in the septum. Intra-op and post-op care, essentially the same. We're doing the same thing for all patients. And during our cardiac surgery module, I'll tell you all about pre and post-op goals, what we have for the patient. Don't bleed, wake up, don't have a stroke, don't have renal failure, wake up and walk out of the hospital is our goal for everybody. But these patients with double valves may often have heart blocks requiring pacer. So your patient comes out of the OR and they're being paced and they're asystolic underneath. Surgery, or your patient who your cardiologist put in pacemakers, don't want to rush and put a pacemaker in right away because their conduction system may wake up and smell the coffee and turn back on. So many times by post-op day 2 or 3, not giving the patient any amiodarone, no low pressor, no slow heart rate lowering drugs, patient's rhythm comes back. They're in sinus rhythm. They didn't need that pacemaker. If by day 3 they're still asystolic or in heart block, they probably do need a permanent pacemaker. Longer surgery time, longer anesthesia time. So some of these patients take a longer time to wake up after surgery and have a little bit more, maybe a more lengthy hospital stay. So valve, what do I want you to remember about the valves? Remember the atrium, the valves, the ventricles, and the aorta and the pulmonary artery. Just remember the pressures. That's the hemodynamics. If the patient has mitral stenosis, you know that left atrium is working as hard as it can, and it can't get blood to the left ventricle, so the left ventricle is squeezing as hard as it can, but there's no cardiac output. Patient has heart failure. With aortic stenosis, that heart is pumping as hard as it can, but there's nothing coming out. With regurgitation, the patients all have terrible heart failure and pulmonary edema. So remember the complications. Remember the problems that we see. Remember with diastolic heart failure, they need filling pressure in their heart. They need volume. If you try to diurese them too quick, they're going to have no cardiac output. Many of them are going to have atrial fib and all the complications we see with the low back pain of cardiology. All right, so that's valvular disease. There's lots of questions because it's very interrelated with the heart failure and the heart failure medicines, preload, afterload contractility. All right, so that's the end of this particular section. So please let me know if you have any questions, and I'll see you for the next module. Thanks.